A 50-year-old woman presented with 1-year history of recurrent episodes of right upper abdominal pain. She has now had jaundice and fever for the past 4 days. On examination, she had a temperature of 38.4, so that's the triad for Charcot's triad for ascending cholangitis. What is the next best step? I would say it is an ERCP. Yes. So this patient has cholangitis and has the full set of the classic features of the Charcot's triad: fever, pain, and jaundice. Her hypotension and tachycardia suggest significant sepsis. Her ultrasound suggests that gallstones blocking the common bile duct are the source, for which the definitive management is to relieve the pressure in the obstructed biliary system. ERCP is the typical route by which this is achieved. What we do is endoscopic bile duct clearance. Why not a laparoscopic cholecystectomy? It's indicated in people with recurrent problems related to gallstone disease, but it's not safe to perform at this time. There's a great deal of inflammation, and the general rule is that we do not do a cholecystectomy when there is acute inflammation going on in the gallbladder. A randomized controlled trial recruits 300 patients to receive either standard treatment or a new compound. The main outcome is a measure of disease severity rated on a scale of 0 to 10. The average score in the group receiving the new compound is 8.2 compared with 4.5 for those on the standard treatment. So the treatment group had a higher score. Which of the following should be concluded? A large study needs to be undertaken. The new compound is significantly better on measures of disease severity than the standard treatment. I think the answer is this one. The new compound is significantly worse. The severity scale is a valid measure. The severity scale is not sensitive. It's significantly better because p is less than 0.5. The p-value is key here. Okay. A study is undertaken to investigate the impact of simple hygiene measures on the rates of MRCA contamination of doctors' tourniquets. A random sample of tourniquets is swabbed before the intervention, and a second random sample is tested after the intervention. The results are presented in a 2x2 contingency table, and the reduction in MRCA contamination rates is tested with a chi-square test. The result of the chi-square test is reported as x power 2 is equal to 4.8 and p is 0.03. 3% of If the experiment were to be repeated 100 times, the probability that a difference of this magnitude would have occurred by chance is 3%? I don't think so. Wait. Oh yeah, exactly. The probability that this intervention has that's the answer. In a chi-square test, the p-value refers to the probability that a result of equal or greater magnitude to the actual result of the study would have occurred by chance if the intervention has no effect, i.e. if the null hypothesis is true. Therefore, in this case, the p-value represents a 3% probability of the difference occurring by chance. Okay. A patient has been diagnosed with autosomal dominant polycystic kidney. The second most common organ that will be affected is the liver, and then I think is the brain. The brain is not even mentioned here, so it's the liver. Hepatic cysts occur in 40 to 90% of patients with autosomal dominant polycystic kidney disease, very rarely causing liver failure. The gene responsible has been found to be localized to the short arm of chromosome 16 in most cases, but 10% have an abnormality in chromosome 4. The renal cysts form along the entire length of the renal tubule. However, in the less common recessive form, they occur in the collecting ducts, and cerebral aneurysms occur in 10 to 20% of patients. I think that's the third most common ones. And then the fourth are pancreatic. A 22-year-old golfer presents for review. He has noticed a decrease in his grip strength over the past few weeks and pain over his elbow. On examination, he has pain over his elbow, which is worse on wrist flexion and resisted forearm pronation. So that's golfer's elbow, that's medial epicondylitis. There is weakness of the adductor pollicis muscle and loss of pinch grip, as well as loss of sensation over the fourth and fifth fingers of the hand. So it's medial epicondylitis. And That's the ulnar nerve distribution. The medical intervention is with physiotherapy and non-steroidal drugs. Okay. A 19-year-old man is currently admitted under the immunologists for investigation of intermittent episodes of periorbital and perioral edema. He takes up to 72 hours to recover from each attack. He has a significant family history with a 12-year-old brother who unfortunately died during a similar attack. You review him once recovered. His blood pressure is normal. His pulse is normal. There are no skin rashes and his breathing is normal. So what's the issue? The issue is the periorbital and perioral edema. Okay, so I think this is a C1 inhibitor deficiency. Let's look at the labs very quickly. Okay, that's my diagnosis. So yes, this is a hereditary angioedema, the most common cause of which is C1 inhibitor deficiency. So a 40-year-old man who has Crohn's disease confined to the colon is reviewed in clinic. He has been suffering from diarrhea more than 6 times per day, which has been unresponsive to corticosteroids and mesalazine, which he has been taking for 3 weeks. He'd also had an exacerbation earlier in the year, and that required a weaning dose of corticosteroids. So basically, we need to kind of increase his treatment. So what is the most appropriate next treatment? The next treatment after corticosteroids and mesalazine is azathioprine, and I think that's why they told us that the TPMT level was within normal limits, because if it wasn't, then there would be a problem. So let's read. For people with Crohn's who have had at least 2 exacerbations within 12 months requiring corticosteroids, the next most appropriate drug treatment from the other options given is azathioprine. Azathioprine is a member of the thioprine class of medications, with the other major member being 6-mercaptopurine. Patients taking thioprines need close monitoring for the potential complications associated with these medications, including myelosuppression, abnormal liver enzymes, and/or pancreatitis. Before thioprines may be commenced, assessment of the patient's level of TPMT is required. Patients that lack TPMT should not be given thiopurines, while those with low levels should be started on reduced doses. Although not listed here, another potential therapeutic option would be anti-TNF, infliximab or adalimumab. However, most clinicians would still only start anti-TNF therapy should the patient still be experiencing active Crohn's despite the use of ethioprine and/or methotrexate. An exception to this would be fistulating Crohn's, where anti-TNF therapy is often commenced early. Okay. Next. A 24-year-old man is admitted after falling asleep drunk in a toilet cubicle. On examination, his blood pressure is 130/70, pulse 98, no pericardial rub. There is boggy tenderness of his right calf and both thigh muscles. So his urea is high, creatinine's high, bicarb is low, pH is low, potassium's high. This is a rhabdomyolysis, I think, and the answer would be a hemodialysis, I guess. Okay. So a raised creatine kinase suggests rhabdomyolysis. The resulting kidney disease is due to the toxic effects of myoglobin upon the renal tubular cells. In this situation, given the potassium and significant acidosis, the patient already has 2 indications for emergency hemodialysis, which is the pH and the potassium. Okay. The patient in the present case will probably require fasciotomy, so continuous therapies that are slower and require anticoagulation are not ideal. Rapid correction of the life-threatening hyperkalemia and acidosis is necessary. Okay. So a 37-year-old homeless patient is found on the floor confused and unwell. He is brought to the emergency department by the police. After some prompting, he denies any past medical history or regular medications. He says he hasn't eaten in nearly 2 weeks. On examination, his blood pressure is 100/80, pulse 95. He looks malnourished and weak with a BMI of 17. He is admitted on the wards, and a dietitian makes a plan with the ward team on the best way to reinstitute feeding. Which of the following are you most concerned about? I am most concerned about in a malnourished patient, and there's a dietitian making a plan. I'm concerned about hypophosphatemia because of refeeding syndrome. In this situation, with a prolonged period of low calorie intake, refeeding syndrome is a possibility. This is characterized by hypophosphatemia, which can drive generalized muscle weakness, cardiac failure, and rhythm disturbance, and is a potentially fatal condition. A hypophosphatemic state normally develops within 4 days of feeding, commencing in at risk patients. These patients require close monitoring of blood biochemistry with dietitian involvement. Okay. So a 24-year-old man presents with intermittent bloating and abdominal pain relieved with passing stools. His symptoms have persisted for the last few months with no weight loss. External physical examination and rectal examination are normal. For the labs, they are also normal. Which of the following tests is required before confirming IBS? And, well, I mean, what is required before confirming IBS? I don't know. Should we do a CT or something? Like, what are the symptoms? Bloating, abdominal pain. I think celiac serology. Let's just do a CT abdomen. Okay. So, celiac serology is required before confirming IBS. CT abdomen is not indicated. There's a very low risk of significant intra-abdominal pathology. Yes, that's true, and the patient's 24, very young. So, in the presence of a normal hematology and biochemistry screen and normal physical examination, makes IBS the most likely diagnosis. Celiac disease may, however, be a possibility and should be excluded, particularly as it can mimic the symptoms of IBS. If it proves to be positive, following a gluten-free diet may significantly impact his symptoms. Okay, so before confirming IBS, you should check for celiac. Which pathological change favors the diagnosis of ulcerative colitis rather than Crohn's disease? Well, I want to say crypt abscess, but I also want to think a little. So granulomas, ileal involvement, that's definitely not favoring ulcerative colitis. Skip lesions, I think that's also not favoring ulcerative colitis, and transmural also does not favor. I'm going to choose crypt abscess, and let's see. So yes, Crohn's disease may involve any segment of the alimentary canal, but terminal ileal involvement is the most common finding in Crohn's, okay? So that's why it's not favoring ulcerative colitis. The inflammatory process involves the full thickness of the bowel wall with the formation of strictures and fistulae occurring in complex disease. Discontinuity of the inflammatory process across the bowel, also known as skip lesions, is characteristic. In ulcerative colitis, there is diffuse, continuous involvement of the colon with proctitis as an early feature in 90% of cases. The inflammation is confined to the mucosa and lamina propria with crypt abscess formation. Ileal involvement is not a common feature of ulcerative colitis, but the distal segment of the ileum may become involved if inflammation within the neighboring cecum is able to spread proximally, which is called backwash ileitis. And here's a summary of the changes. So, for ulcerative colitis, it has crypt abscess, an inflammatory cell infiltrate, and only the mucosa and submucosa are involved. But in Crohn's, it's transmural, and it has a lot of ulcers and lymphoid aggregates and granulomas and neutrophil infiltrates and everything. Okay. So, 64-year-old man, he presents to the GP complaining of shortness of breath and dizziness. He has no symptoms of GI disturbance, and apart from a past history of hypertension, which is managed with amlodipine, he has no significant known medical illness. On examination, he looks pale, his blood pressure is high, and his hemoglobin's low, and his MCV is low, and I'm pretty sure in an old patient with anemia, we should always do a colonoscopy first. But, okay, yes. So, without any history of GI disturbance, the highest index of suspicion here would be for a right-sided colonic lesion. So, colonoscopy would be the investigation of choice, particularly given his age. If this is normal, then upper GI endoscopy would be the next most appropriate investigation. So it also tells us that most colorectal cancers are located in the descending and sigmoid colon, and these typically produce localizing symptoms such as altered bowel habit and rectal bleeding, because the tumor is disturbed by transiting solid feces. The absence of these symptoms suggests it may be in a less common location, such as the right-sided ascending colon. Symptoms are less common in this region because, as enteral contents enter the ascending colon from the small intestine, it is still in the form of liquid chyme. Hence, a tumor which is non-obstructive in this area is not subject to the same force of friction as would be the case in the descending and sigmoid colon, where solid feces has begun to form. Okay. So, a patient has been diagnosed with a fast-growing pituitary adenoma, and the MRI scan reveals a suprasellar extension. So, which structure is most likely to be affected by tumor compression? Well, we already know that the pituitary adenoma causes hemianopia because of the optic chiasm. So, I'm just going to say it's optic chiasm. The pituitary gland occupies the sella turcica, which is a cup-shaped depression in the basisphenoid bone. The roof of the sella is formed by the diaphragma celli, a fold of dura, which is perforated to allow passage of the pituitary stalk. Above the diaphragma lies the suprasellar cistern, the optic chiasm, and the anterior cerebral arteries. The chiasm is most likely to be subject to compression by pituitary tumor. So why is it not the other ones? I just want to take a quick look. Why not the hypothalamus? Pituitary tumors don't usually lead to hypothalamic dysfunction, but hypothalamic tumors can lead to okay. A 20-year-old man is referred for investigation for hypogonadism and infertility. He went through normal puberty and there is no significant family history. On examination, he is tall with gynecomastia and a small testis. He has a normal sense of smell, so this is not Kalman. It could be Klinefelter. It looks like Klinefelter. I feel like in Fragile X, I remember everything was big, and here he has a small testis, so I think it's Klinefelter. It's not Marfan, and no, okay, it's Klinefelter. Yes, Klinefelter occurs due to the presence of an additional X chromosome. It is the most common sex chromosome abnormality and the most common cause of male hypogonadism and infertility. Affected men tend to be tall and have an increased risk of mild intellectual impairment. They also have an increased risk of osteoporotic fracture due to low testosterone. For Fragile X, as we said, it's associated with macroorchidism and moderate to severe learning disability. It occurs due to mutations in the FMR gene. Okay. A 78-year-old retired textile worker is noted to have painless hematuria on routine urinary dipstick by her GP. Her only past history of note is arthritis, for which she takes anti-inflammatories. Plain abdominal X-ray reveals no evidence of renal stones. Routine bloods reveal increased plasma viscosity and mild anemia, with a hemoglobin of 105 and a ferritin just below the normal range. Which of the following is the most likely diagnosis? So, she has painless hematuria. She's on anti-inflammatories. She has increased viscosity, and well, I think she has mild anemia and a low ferritin because of the bleeding. I would say it's bladder cancer, but just because, well, she has a risk factor, which is occupational. She's old, and she has painless bleeding, and that's the only thing that fits, really. Okay. Bladder cancer has an increased association with cigarette smoking, occupational exposure to dyes or petroleum products, and chemical exposure to nitrosamines. Later stage disease may also precipitate abdominal pain or kidney disease due to obstruction. In the Western world, around 93% of bladder cancers are transitional cell type, 6% are squamous cells, and less than 1% are adenocarcinomas. By the time of the diagnosis, around 70% are still localized to the bladder, 20% involve the regional lymph nodes, and 3% present with distant metastasis, and some 80% of superficial bladder tumors are said to recur. Well, bladder cancer characteristically presents with painless hematuria, which may be gross or non-visible hematuria. Treatment of choice for localized tumors is transurethral tumor resection with the use of intravesical chemotherapy when required. So the second most commonly chosen answer was interstitial nephritis. I think people picked this, well, I don't know why people picked it. Is it because of the anti-inflammatories, I guess? I don't know. Okay, I want to read more about these two. So interstitial cystitis presents with lower urinary tract symptoms such as urinary urgency or frequency. Okay. Okay, so just inflammation. For nephritis, it's a common parenchymal cause of unexplained acute kidney disease, usually as a result of drugs. Classically, there is a triad of fever, arthralgia, and rash with renal impairment. There's also modest hematuria and proteinuria, and microscopy of the urine may reveal eosinophils and white cell casts. There may also be eosinophilia in the blood. For analgesic nephropathy, it is frequently due to the use of a combination of analgesics such as aspirin, paracetamol, and codeine. Ischemic medullary injury proceeds to tubulointerstitial scarring, glomerulosclerosis, and papillary necrosis. In this scenario, the lack of flank pain and the presence of hematuria makes papillary necrosis unlikely. Papillary necrosis would cause flank pain. Okay. Next. So, a 53-year-old man presents with a 6-month history of feeling non-specifically well and has recently noticed a rash on his legs and feet. He's breathless. He has had a single episode of hemoptysis. He has 30-pack year smoking history. His hemoglobin's 94. Urinalysis shows dipstick, hematuria, and proteinuria. Midstream urine reveals 100 red blood cells with no white blood cells. Well, why does he have a rash and hemoptysis? Well, bronchogenic carcinoma, pneumococcal pneumonia. No, it's not pneumonia. It's not a pulmonary embolus, pulmonary hemorrhage, or bronchogenic carcinoma. I'm going to choose bronchogenic carcinoma, and I'm just going to guess that this is some sort of paraneoplastic occurrence. Okay, it's not. This is pulmonary hemorrhage. So this is Goodpasture's disease. Okay. So first, let's read why bronchogenic carcinoma is incorrect. Older patients with membranous nephropathy may have an underlying malignancy, which should be sought carefully. However, this does not usually cause hematuria. In this patient, a bronchogenic carcinoma is clearly high on the differential diagnosis list. Well, why did we pick pulmonary hemorrhage instead? The key here was the hematuria, I would say. So the midstream urine sample excludes infection, confirming the abnormal urinalysis to be due to glomerulonephritis. This is a classical history for small vessel vasculitis leading to pulmonary renal syndrome, which may be due to granulomatosis with polyangiitis, GPA, microscopic polyangiitis, or anti-JBM disease, Goodpasture's. This one is Goodpasture's because there's a pulmonary hemorrhage. Is the rash just telling me that there's vasculitis? Probably. Okay. You see an 18-year-old woman who presents to you after assisting at a summer children's party. She says that she has helped to blow up balloons at the party and within 5 minutes had begun feeling unwell. She has wheezing, angioedema, and lip swelling and an urticarial rash. What is the most likely diagnosis? Well, because she has wheezing, I think it's some sort of allergy. It's not a contact dermatitis and it's not hereditary angioedema. I think it's a latex allergy. She developed classic allergy symptoms after blowing up balloons, and most balloons are produced from some form of latex. Okay. Because she had a severe reaction, she should be skin prick or RAS tested to confirm the diagnosis. 23-year-old woman presented with intermittent diarrhea, abdominal pain, and distension. She had also suffered increasing tiredness and lethargy for the past 6 months. Investigations. So her hemoglobin is low, her MCV is high. White blood cells are normal, platelets are normal, sodium's fine, potassium's okay, creatinine's fine, high ESR, and a macrocytic anemia. Okay. Colonoscopy with biopsies showed multiple areas of inflammation and punched out ulcers. Barium follow-through revealed evidence of a severe small bowel inflammation. Given the likely diagnosis, which of the following is the biggest risk factor associated with the development of the disease? The biggest risk factor in Crohn's is wait, is this Crohn's? I think it. I don't know why I said Crohn's, but I think it's Crohn's. Yeah, small bowel. That's Crohn's. So, which of the following is the biggest risk factor? A diet low in soluble fiber, excess alcohol, increasing age, oral contraceptive use, or smoking? I think it's smoking. I'm just going to hope it's smoking. Yes. So, smoking is actually a risk factor for Crohn's, but it's protective for ulcerative colitis. So it contributes by increasing the pro-inflammatory state. So the second most commonly chosen answer was a diet low in soluble fiber, and that would lead to IBS, but not Crohn's. Some macrophages are located at specific points in the body where pathogen entry is more likely. Okay, they just want to know which one is a tissue macrophage. It's the Kupffer cell. And is it the type 2? I'm just going to say Kupffer cell because that's the one I'm sure of. Okay. Kupffer cells are specialized macrophages found lining the sinusoids of the liver, and they account for nearly 90% of the tissue macrophages of the body. Wow, so they're very important cells. Pathogens from the intestine will first travel to the liver via the portal venous system, and consequently, the Kupffer cells are positioned to engulf bacteria, debris, and endotoxins. So the second most commonly chosen answer was the type 2 alveolar cells. These cells are responsible for producing surfactant in the lung and have no macrophage functions. There are alveolar macrophages, but these are a separate cell type. Okay. You're asked to review a 60-year-old man who has been treated for post-operative ileus following colectomy and has a nasogastric tube in place. This has aspirated a considerable volume of gastric fluid. He has a metabolic alkalosis. What is the most important cause of the acid-base disturbance? Loss of gastric acid, obviously. Okay. So, loss of unbuffered gastric acid causes metabolic alkalosis. This is pretty easy. Well, I'm kind of confused now because some people picked D and B. So why? Potassium depletion. This occurs as a result of prolonged vomiting. It's not the direct cause of metabolic alkalosis. Yeah, because the question was asking about the cause of the acid-base disturbance and not just what has happened. Okay. An 18-year-old woman is referred by her general practitioner to the clinic to investigate problems of a movement disorder and abnormal liver enzymes. Is that Wilson? Okay, let's see. Yeah, it's Wilson. On examination, she appears tremulous with some evidence of ataxia as well as dysarthria. So the laboratory tests demonstrate that her ALT is elevated, so the liver is inflamed. Her serum ceruloplasmin is low, and there's increased urinary copper excretion, so she has Wilson's disease. Well, I'm not going to read everything. So the treatment of choice is penicillamine, which acts as a copper chelator. And yeah, okay. An 18-year-old man is brought to the emergency department by ambulance after he's sent in by the local GP emergency service. His friends asked for the home visit as he had not left his room for 2 days and was suffering from a sore throat, headache, and neck stiffness. Examination was reported as showing a pyrexia of 38, high blood pressure, and pulse is 95, plus signs of meningism. The GP was concerned about a maculopapular rash and injected him with IM penicillin. By the time he reaches the emergency department, he's hypotensive and tachycardiac, and there are signs consistent with facial edema and stridor. You suspect an anaphylactic reaction. So they're basically asking about the blood test that would best help make the diagnosis of anaphylaxis, and the answer is mast cell tryptase. I hope that's the answer. I think it's the answer. Yes. So mast cell tryptase is transiently raised in anaphylactic reactions, with peak levels occurring approximately 1 hour after onset. The assay is not widely available, and processing of the samples takes some time. For this reason, tryptase is useful in determining if an anaphylactic event has occurred, but does not impact on immediate management, of course. A 45-year-old man with a history of hypertension is admitted with 3-week history of fatigue, reduced oral intake, and reduced urine output. Investigations, so potassium's 144, sodium's 144, potassium's high, it's 6, urea is also very high, it's 66, creatinine's also very high, 777, chest x-ray shows pulmonary edema, the renal ultrasound shows bilateral small kidneys. A dialysis line is placed into his right jugular vein, and his first session of hemodialysis is commenced with a view to removing 1.5 liters of fluid. 2 hours into his dialysis, he complains of nausea, headache, and blurred vision. His blood pressure was 150/80. Which of the following is the most likely explanation of his symptoms? So why would a patient undergoing hemodialysis experience nausea, headache, and blurred vision? I don't think this is a subdural hematoma. I don't think it's hypoglycemia. I don't think it's intravascular depletion. It could be, but like, why? I'm gonna say it's dialysis disequilibrium syndrome, just because it makes the most sense. So, there's a video, but we don't have to watch it. So, the syndrome is characterized by neurological symptoms observed typically in patients undergoing their first session. Okay, so if it's my first session, getting a hemodialysis, I might get this neurological syndrome. Symptoms include headache, nausea, and blurred vision, but can progress to confusion, seizures, coma, and death. Risk factors include elderly patients, histology of neurological disease, first dialysis, and a very high urea. Why? The pathogenesis is postulated to be due to the removal of urea. So when we remove urea, this lowers the plasma osmolality, which favors an osmotic gradient of water to enter the brain, causing cerebral edema. Symptoms tend to resolve on stopping dialysis. It is now rarely seen in practice as a result of preventative measures for patients undergoing their first session, such as initiating a 2-hour session to begin with and gradually increasing towards 4 hours per day. Okay, next. So, a 45-year-old man comes to your clinic complaining of having epigastric pain for 2 months. His GP prescribed him H2 blockers 3 weeks ago, which have produced only partial relief of his symptoms. His weight is stable, his physical exam is normal. An upper GI endoscope reveals a 1 centimeter duodenal ulcer. Which of the following risk factors are associated with development of ulcer disease? Cigarette smoking, spicy foods, emotional stress, all of them. Well, regular use of paracetamol, moderate alcohol intake. I don't think it's the last 3. Which is the most associated with ulcer? I don't think it's emotional stress either, even though that cause. I'm going to say cigarette smoking. Yes, so cigarette smoking doubles the risk of developing duodenal ulcers. Other risk factors include regular nonsteroidal and corticosteroid use, gastric infection with H. pylori, and Zollinger Ellison, and physical stress. So, physical stress and not emotional stress. Okay, for spicy food and emotional stress, there is no evidence that shows that. Okay. Or actually, the evidence shows that they don't. A patient on a total parenteral nutrition regimen presents with drowsiness and abnormal serum electrolytes. He's also in mild heart failure. He has been commenced on TPN for severe debility as a result of chronic alcoholism. Which of the following is the most likely cause? The most likely cause of what? Of drowsiness and abnormal serum electrolytes. So, what's the electrolyte imbalance that this patient who is chronic alcoholic, has drowsiness and mild heart failure? Is it hypomagnesemia? Could it be? Could it be? No, it's not. It's hypophosphatemia. Oh, okay. Well, I'm confused actually. So, oh, okay. So he started a TPN regimen and now he came with these symptoms. Okay, so refeeding syndrome occurs when starving or chronically malnourished patients are refed. Okay, so this was just refeeding syndrome, which I know, but I just got confused. Oh, what does phosphate deficiency do? It causes weakness of skeletal or smooth muscle. That's the most common, involving any muscle group, alone or in combination, ranging from ophthalmoplegia to proximal myopathy to dysphagia or ileus. Impaired neurological function, which may be manifested by confusion, seizures, coma, peripheral neuropathy, and ascending motor neuropathy. Ascending motor paralysis. Okay, respiratory insufficiency and impaired cardiac contractility. So basically, just like muscles not working and brain, or like nerves not working well. Okay, so you're reviewing the protocol for a new outcome study designed to detect the impact of a blood glucose lowering agent on cardiovascular events. You note that it has a power of 90% to detect 15% relative risk reduction in major cardiovascular events. Um, well, I forgot what power was, but I'm going to try. So, which of the following best describes the statistical aspect of the study? 90% of subjects need to be exposed to study medication to achieve a positive result. Um, no, no, I don't think so. Wait, what does that mean? What does that even mean? Okay, the study has a specificity of 90%. There is a 90% chance no benefit will be found. There's a 90% chance of capturing a real benefit of 15% if it exists. Yeah, I think that's the one. Mm-hmm. Power is synonymous with sensitivity and describes how sensitive a given study is with respect to capturing the benefit of a predefined magnitude or the percentage change of correctly rejecting the null hypothesis. Okay, so the explanation is not complete, so let's give them feedback. Okay. A 22-year-old woman presents to the clinic with an intensely itchy bullous rash affecting her scalp, elbows, knees, and buttocks. She tells you she scratches her skin raw to the point of bleeding. On exam, there are numerous small blisters, some as large as 1 centimeter. She has no other past medical history of note, and her only regular medication is the oral contraceptive pill. Important investigation. Well, let's look at the labs. So she has microcytic anemia and hypoalbuminemia and high ALT. So what does... Oh, okay. I think I know what this is. Is this cutaneous porphyria? Maybe not. But the thing is, I don't know what I should measure because... is this dermatitis herpetiformis and I need to measure the TTG antibodies? Yeah, okay. Whilst there are no bowel symptoms, this patient has a rash consistent with dermatitis herpetiformis and unexplained anemia. Therefore, anti-TDG antibodies as a screen for occult celiac disease are a logical next step. The second most commonly chosen was ANA. Okay. 42-year-old man presents to the clinic with episodes of constipation and rectal bleeding over the past few months. He has no other past medical history of note and takes no regular medication and exercises regularly. On examination, his blood pressure is 122/72, pulse is 70 and regular, BMI is 23, abdomen is soft and non-tender. Investigations reveal that he has an anemia and high ESR, and that's it. So what is the next investigation of choice for a man who has constipation and rectal bleeding? He's 42. Should I do a colonoscopy? I think so. So, yes, that's the answer. The lower GI symptoms coupled with anemia and raised ESR in this age group point to possible IBD. Okay. Next. A 24-year-old woman comes to the clinic for review. She has chronic diarrhea which floats and is difficult to flush away. Apparently, she tried to avoid weight-containing products a few months earlier and noticed some improvement in her symptoms. She has a past history of allergies but nil else of note. On examination, her blood pressure is 95/60, pulse is 78 and regular. She is thin with a BMI of 19.5 and has bilateral swelling of her ankles. So she has steatorrhea and she has a gluten sort of... I just want to check that this is the answer before moving on. She's endomysial negative. Okay, she's celiac. I don't care. Yeah. So some people picked Whipple. I think they got confused by the negative anti-endomysial antibodies. This patient has symptoms consistent with celiac, yet the endomysial antibody screen is negative. The past history of allergies raises the possibility of IgA deficiency, which is associated with celiac, and is it associated with celiac? I don't remember. Anyways, that the anti-endomysial antibodies are negative because an IgA-based assay rather than an IgG1 was used. Okay. In Whipple, there would be a polyarthritis, and it's also rarer versus celiac. A 72-year-old bipolar patient is seen in the renal new patient clinic complaining of thirst for 6 weeks. He is not previously known to have CKD. So, his urea is very high. His creatinine is also high. His sodium is a little bit on the... Okay, it's also high. And his urine osmolality is low. So I think this means that this patient is... Well, this is diabetes insipidus, I guess. So is it... Well, it's either nephrogenic or psychogenic. I know that psychogenic is much more common, but there is... I need to look at the urine osmolality. So, in a psychogenic polydipsia, would the urine be concentrated or not? Okay, I'm gonna say nephrogenic. These questions always confuse me, but I'm pretty sure that this is the defining feature, so let's see. It is likely to be a direct toxic effect of long-term lithium therapy. Nephrogenic diabetes insipidus may also be inherited as an X-linked recessive condition. Yes, so it's either caused by the lithium or it's inherited. The diagnosis is made on the low urine osmolality, less than 200, in the presence of a raised serum osmolality, hypernatremia, and dehydration. And the treatment is just adequate hydration and reduced sodium, and also amiloride. So why is it not psychogenic? Because hypernatremia would not feature in primary polydipsia. And the diagnosis of DI in this case, if there was no hypernatremia, would be by a water deprivation test. A patient with primary polydipsia would produce less urine output after water deprivation than a patient with DI, which means that the excessive intake was the driver to the polydipsia. And it's not cranial because the patient had a history of bipolar disease. Okay, a 55-year-old geography teacher was referred for management of obesity. He has a BMI of 36. His investigations showed a cholesterol 7.7. Let's see the normal values. Okay, so it's high. Fasting triglycerides are high. ALT is it's high, I guess. He denied alcohol excess. What is the significance of his raised liver enzymes? What is the significance? Well, this is a very metabolic. It's very significant actually, but it's not cirrhosis yet. It's consistent with NASH, but I just want to see if it's okay, it's very elevated. So this is consistent with NASH. Okay. So some people said that this is low significance, should be monitored, but it's not, because people with MASLD, metabolic something liver disease, with more severe features of metabolic syndrome are most likely to have advanced liver disease. This man has a very abnormal BMI and also his lipids. Okay, it's kind of too severe to be low significance. So, metabolic dysfunction associated steatotic liver disease, MASLD, is rapidly becoming one of the most common causes of chronic liver disease in the world. It is often found in association with other features of the metabolic syndrome, such as hypertension, dyslipidemia, obesity, and diabetes mellitus. It represents a spectrum of liver disease ranging from simple fatty liver to non-alcoholic steatohepatitis. It is now recognized that metabolic dysfunction associated steatotic liver disease related cirrhosis is probably the major cause of what was previously termed cryptogenic cirrhosis. Okay, I just wanted to know more about this term. A week after an episode of infected diarrhea, a 17-year-old teenager presents with fever, hypertension, and hematuria. You understand that he had been doing work experience at a farm for a short period before he became unwell. Blood tests reveal anemia with a hemoglobin of 84 and an elevated creatinine. So, what is this thing that causes diarrhea, fever, hypertension, and hematuria? Is it hemolytic uremic syndrome or post? I think it's hemolytic uremic syndrome, and I think he got infected with it, the toxigenic E. coli strain. So hemolytic uremic syndrome is characterized by microangiopathic hemolytic anemia and acute kidney disease. Working at a farm implies HUS is the most likely. Oh, okay. Well, yeah, because that's how he got infected with the E. coli strain. A 23-year-old woman is reviewed in the gastroenterology clinic. She presents with diarrhea, weight loss, and an intensely itchy rash, and gluten-free diet. We just did a question on celiac. So a 20-year-old man is admitted to the emergency department after a road traffic collision. He has no relevant past medical history. Upon examination, he has a blood pressure of 80/60 and a high pulse rate. Urine dipstick shows +3 blood. Blood results show urea 15 and creatinine 800. What is the single most important biochemical factor that should be kept in mind in a patient who had a traffic accident and is kind of shocked and has hematuria and his blood urea is 15 and creatinine's high? Well, the single most important biochemical factor is going to be acidosis leads to the movement of potassium from the extracellular to the intercellular fluid compartment, or adrenaline inhibits the entry of potassium into cell, increasing the plasma potassium level. No, that's not the answer. Hyperkalemia is associated with increasing blood pH. Potassium release from the muscle cells leads to gluconeogenesis. That is the answer. That's the only thing that makes sense. Okay, this patient has rhabdomyolysis and acute kidney disease. The most important biochemical factor that may cause arrhythmia is hyperkalemia. Yeah, you could have just put hyperkalemia in and I would have chosen it. A patient presents with hypocalcemic tetany. What is the most likely diagnosis? He has abnormal ears, hypertelorism, and an absent thymus. That's Teichwort syndrome. Um, it's a gene defect in chromosome 22. The patient will have congenital heart defects, hypocalcemic tetany, and absence of a normal thymus. Okay. A 51-year-old woman presents to the clinic with dry, gritty eyes and recurrent stomatitis, for which she has visited the dentist on multiple occasions. Let's just look at the. Okay, let's not. Let's go back. Over the last 6 months, she also presented to the GP with parotitis. She has increasing fatigue and describes Raynaud's phenomenon. Examination reveals blood pressure 135/85, pulse 75. She has bilateral blepharitis. There's bilateral parotid enlargement and pain on joint palpation of the wrist and fingers. So she has peripheral polyarthritis. For her labs, they are fine, except for the fact that she has a high ESR, a positive anti-nuclear antibody, and rheumatic factor. Well, it's Sjogren just because of the symptoms, but I don't know the significance of the antibodies. Okay. Well, it mentions joint pain, so, but it's okay. A 35-year-old man is referred to you with altered bowel habit and weight loss. One of his sisters had a hysterectomy for uterine cancer, and another sister had colorectal cancer. His father died from colorectal cancer. So this is APC something. Yeah, it's this one. Is it fat? No, I think it's. Oh, I think it's this one. What? Okay, so. Familial adenomatous polyposis is incorrect. This is characterized by profuse colonic adenomatous polyposis, much greater than that seen here. Oh, few polyps. Okay. Affected individuals develop hundreds of polyps by their second decade. For HNPC, this is Lynch syndrome, and it's associated with uterine cancer, and, well, other sort of cancers. Endometrial cancer specifically. So, HNPCC is an autosomal dominant inherited predisposition to colorectal cancer in the absence of florid polyposis. So that's why it said non-polyposis. There are polyps, but they're not as much as in FAP. So there are two main forms. Lynch 1, there's no family history. Lynch 2, there are other cancers in the family, such as endometrial, ovarian, and urinary tract. Okay. Okay, so there is a nice information that the genes that are responsible for HNPCC are related to. Okay, let's read that. They're involved in repairing DNA sequence mismatches. Okay. A 23-year-old man presents to his general practitioner with rapidly increasing shortness of breath and hemoptysis for the second time within 3 weeks. He's referred urgently to the medical on-call team. Apart from smoking 20 cigarettes per day and having mild asthma, he has no other significant past medical history. Urinalysis reveals non-visible hematuria and proteinuria. Chest x-ray reveals fluffy pulmonary infiltrates. Hemoglobin is 105, serum creatinine is 345, serum ANCA is negative. Which one of the following diagnoses fits best with this clinical picture? Well, hemoptysis and fluffy pulmonary infiltrates and renal affection. ANCA is negative, so I don't want to choose GPA. But also, okay, I think it's anti-GBM. Because of the hemoptysis, really. So the negative ANCA makes, yeah, okay. So anti-GBM has a male to female ratio of 6:1. It accounts for 5% of cases of rapidly progressive glomerulonephritis. It's characterized by a triad of glomerulonephritis, pulmonary hemorrhage, and the anti-GBM antibodies, and 80% are HLA-DR2 positive. The treatment, prednisolone and cyclophosphamide or plasma exchange. Okay. Next question. A 65-year-old woman with long-standing diabetes taking anti-diabetic treatment presents with proteinuria. Apart from her diabetes, she has no other past medical history of note. Her serum creatinine and HbA1c level is normal. What would be... Oh my god, I can't read anymore. What would be the most common renal complication in this case? For a patient with long-standing diabetes, the most common renal complication would be... glomerulosclerosis, which is also known as Kimmelstag-Wilson syndrome, a cause of nephrotic syndrome. A lot of people picked renal papillary necrosis. It may occur in diabetics because they're prone to UTIs. However, okay, this guy has no abdominal pain. Okay. A 23-year-old woman developed severe watery diarrhea 10 days after receiving both a quinolone and a cephalosporin following childbirth, complicated by infection. Okay, she was unwell. Well, this is C. diff, and we would start Cipro, I guess. Could be wrong, could be right, probably right. Wrong! Why not Cipro? Wait. I'm confused. Okay, then I didn't study the treatment of C. diff then. So, the abnormal rectal mucosa seen on proctoscopy together with the recent complicated childbirth makes C. diff. Well, I know that. Vancomycin is the first line treatment of C. diff. I didn't know that. I should know that. That's like bare minimum knowledge to have. Okay. 21-year-old allergy to peanuts is admitted as an emergency. They're just asking that in a patient with anaphylaxis, I want to give adrenaline or epinephrine. What's the most appropriate route? He didn't have his adrenaline auto-injector pen with him. The most appropriate is intramuscular. Yeah, exactly. You're evaluating a patient with symptoms consistent with profound arteriopathy. Blood is circulated through the arteries by which one of the following physiological mechanisms? Yeah, okay. Arterial elasticity, contraction of external muscles. It's contraction of the smooth muscles in the vessel. Negative pressure, no. Residual pressure from blood flow through the capillaries, maybe. Suction. I'm gonna say contraction, but I'm just scared of choosing this because... No, it's this one. It's probably this one. Okay, it's not. Well, why is it not contraction? The question asks... oh, right. The contraction of external... Oh, yeah. So... Okay. So these all promote venous blood flow, but for arterial, the arterial elasticity and the ventricular systole and the recoil of the elastic aorta are what drive blood flow in the arteries. Which one of the following statements best describes the standard deviation? It's a measure of how close the sample mean is to the population mean. No. It's a measure of the spread of the sample distribution relative to the mean. Yes. It is derived from the difference between the mean and the median. No. I'm going to choose this. It's derived from the square root of the variance. A higher standard deviation represents a greater spread of values. A 48-year-old woman with known renal disease presents to the emergency department. Her admission biochemistry profile shows a serum potassium concentration of 6.2. Her ECG is abnormal. Which ECG abnormality is most likely to have occurred earliest as her hyperkalemia developed? Well, the ECG abnormality that has most likely to have occurred earliest. Okay. So they're asking about the ECG changes in hyperkalemia. This is the most severe. It's one of these: prolonged PR interval, prominent U waves. I'm going. I don't know actually. I'm scared. I'm going to choose this. Oh. This is typically seen when potassium is greater than 6.5 and represents progressive paralysis of the atrium. Okay. Prominent U waves is a feature of hypo. Reduced P wave is incorrect. It's also seen when potassium's high. Sine wave is a preterminal. Yeah, I knew that. So tall tented T wave is typically seen early in the time course of hyperkalemia. So I probably need to revise the ECG changes in hyperkalemia. I just revised them now. Okay. So a 35-year-old man was admitted after a 32-day period of starvation. His body mass index was 17 and he estimated that he had lost 18 kilograms in weight. He was commenced on enteral feeding. Which of the following is the most serious consequence of refeeding syndrome? It's hypophosphatemia. Okay. So, this one is going to actually tell me what happens, and that's nice. So, refeeding syndrome is driven by insulin in response to the intake of calories after a prolonged fast. The insulin drives potassium and phosphate into the cells, leading to acute hypophosphatemia. Although all of the other biochemical parameters given as options in the question may also be found in a person with refeeding syndrome, hypophosphatemia is the one with the most profound implications for tissue dysfunction, making it the correct answer here. Okay. Which of the following disorders is most strongly associated with Helicobacter pylori infections? Well, none. Okay, gastric lymphoma. Out of these options, it's gastric lymphoma. Okay. An 18-year-old man presents with dark discoloration of urine. There is a history of upper respiratory tract infection with severe pharyngitis 2 weeks earlier. Okay. He was previously fit and well on exam. He has a puffy face with periorbital edema. His blood pressure is 150/90. Given the likely diagnosis, which one of the following is the most likely to occur? Proteinuria, I guess? Because the rest are just too, weird. Yeah. So some people said it's acute kidney disease requiring dialysis, and I'm going to assume that it doesn't cause that. Kidney disease occurs in less than 1% of cases. The likely diagnosis here is post-streptococcal glomerulonephritis, the clue being the preceding upper respiratory tract infection. The typical presentation is that of clinical nephritis with hematuria and edema, plus minus hypertension, which leads to significant proteinuria. Okay. A 52-year-old man presents with an acute upper gastrointestinal hemorrhage, but he has no further bleeding after the initial episode. Upper gastrointestinal endoscopy reveals a suspicious ulcer, which is biopsied. This reveals the presence of mucosa-associated lymphoid tissue and Helicobacter pylori. What is the most appropriate initial treatment in this case? Obviously eradication, just eradicate it, because this is a lymphoma and the treatment of the mucosa associated lymphoid tissue is eradication of the H. pylori. A 55-year-old man complains of intermittent epigastric pain, diarrhea, and steatorrhea. He has mild iron deficiency anemia and raised calcium and parathyroid hormone levels. An upper GI endoscopy has shown peptic ulcers in the stomach. duodenum, and jejunum. Which of the following tests is most likely to help in diagnosis? Uh, so I don't know. I think this is a Menon syndrome just because he has hyperparathyroidism as well. And I want to say serum gastrin level. So, the presence of multiple ulcers and hyperparathyroidism suggests Zollinger-Ellison syndrome. It's caused by pancreatic tumor. So that's why serum gastrin levels are helpful. If this man's diarrhea was thought to be attributable to malabsorption, there would be a potential role for small bowel follow-through, stool fat, and for duodenal biopsy. However, his diarrhea seems much more likely to be caused by a gastronoma. A 32-year-old alcoholic is admitted for nutritional support. According to a relative, he has spent all of his money on alcohol and has had very little to eat for the past few weeks. There have been multiple previous admissions for acute confusion, pneumonia, and collapse. On examination, his BMI is 20, his blood pressure is 100/60. There are signs of chronic liver disease and with ascites and spider nevi. He begins a TPN regimen. He suffers a decreased consciousness and a short tonic-clonic seizure. In this case, deficiency of which one of the following is the most likely cause? It's phosphate, and we just read that phosphate causes muscle problems and nerve problems. Okay, so 50 questions are enough for today, and see you next time. So let's end the session.